Okay, let's unpack this.
Let's do it.
We are embarking on a deep dive today, really tackling the massive, complex field of orthopedic surgery.
Yeah, it's vast. And this isn't just a surface skim, right? We're pulling foundational knowledge, the real principles, directly from surgical experts.
Exactly. Our goal is comprehensive, structured mastery for you, the listener. We're aiming to cover the entire musculoskeletal landscape.
Everything from, immediate trauma management, complex fracture fixation,
All the way to joint replacement strategies, sports medicine dynamics, spinal issues.
musculoskeletal oncology, and even the unique challenges you see in pediatric orthopedics. It's a huge scope.
So if you're aiming for that elite professional level of understanding, really getting the why behind the decisions, then this is your mission brief.
It's a lot of ground to cover, so maybe we should just dive straight into the high-stakes stuff. Core principles of orthopedic trauma and emergencies.
Good call. Let's start there.
Well, it's kind of a fundamental truth in medicine, isn't it? The vast majority of complaints you see, whether in the emergency department or even outpatient clinics, they involve the musculoskeletal system.
Absolutely. So having a basic grasp of how to manage these injuries is essential for pretty much any physician, regardless of their specialty.
And when we talk about treating a fracture, the goals are actually quite broad. It's not just about, making the bones stick back together.
Right. You're aiming to restore normal anatomy.
Yeah.
That means getting the length right, the alignment, the rotation.
And stabilizing the injury quickly, allowing for early mobility if possible.
Minimizing complications like infection or stiffness, and end of the day, getting the patient back to their pre-injury function. That's the real goal.
And to hit those goals, you first have to know what you're looking at. What's the injury pattern?
Our sources detail the common ways bones break, the morphologies. You've got your simple transverse break, straight across.
The twisting ones, oblique or spiral. Then there's segmental, where a whole piece is broken out.
And the really messy one, comminuted, where the bone is basically shattered into multiple fragments.
So where do we start with treatment? Often it's non-operative. Immobilization.
Yeah, a splint or a cast, but here's a really critical point, especially early on. Acute injuries swell a lot.
Exactly. So you absolutely prefer non-circumferential splints at first. You have to give that soft tissue room to expand.
Otherwise, you risk pressure buildup, cutting off blood flow, ischemia.
Not good. Definitely not. Now, if the fracture is way out of place, significantly displaced or angulated, the first move is often closed reduction.
And this isn't just random pulling, is it?
No. It's methodical. You apply axial traction, kind of pulling along the line of the bone, and then you carefully reverse the mechanism of the injury. You try to guide it back the way it came out.
Okay, makes sense. And after you do that?
Immediately afterwards, you absolutely need imaging to confirm you got it right, and a very thorough neurovascular exam.
Why the exam right then?
Because the act of reducing the fracture itself, even if done carefully, could potentially stretch or pinch a nerve or a blood vessel. You have to check.
Got it. So that covers non-op and reduction. What about fractures that just won't stay put, the unstable ones?
Right, which honestly is the majority of major long bone injuries. That's when we turn to internal fixation, surgery.
And the core principle here, it's not just about union, is it?
No, it's about creating a construct, a framework that's stable enough for the bone to heal in the right length, alignment, and rotation.
While also letting the patient start moving and using the limb relatively early. That early function piece is key.
Absolutely. And that stable construct relies on specific bits of hardware. Screws, for instance.
What's their main job?
They're primarily used to create interfragmentary compression, squeezing the bone fragments together right across the fracture line.
And that compression promotes a specific type of healing.
Yeah, primary bone healing, direct healing without a big callus bump. Plates are different. They act more like stabilizing bridges or buttresses, holding the cortex alignment.
Okay, screws for compression, plates for bridging. What about the big long bones? Femur, tibia?
For those, we heavily rely on intramedullary, or IM, rods. Rods that go down the hollow canal inside the bone.
How do those work?
Yeah.
You drill out the canal first?
Often, yeah. Reaming the canal allows for a larger, stronger rod and maximizes contact between the rod and the bone for a snug fit. Then you insert the rod.
And it just sits there.
Not quite. You lock it in place. Locking screws are inserted proximally and distally, going through holes in the rod and into the bone cortex.
Ah, so that stops it from shifting or rotating. Static locking.
Exactly. It makes the whole construct stable against bending and compression forces, which is crucial for bones you need to bear weight on.
But what if the patient is just too sick for a big surgery right away? like a major trauma.
That's a critical scenario. It brings up the concept of damage-controlled orthopedics.
Damage control.
Meaning, if you have a polytrauma patient who's hemodynamically unstable, maybe bleeding elsewhere, or the injured limb is just massively swollen and the soft tissues are compromised.
Doing a long, complex internal fixation surgery right then could actually be harmful, even dangerous for the patient.
Precisely. In those cases, we opt for external fixators first.
Those are the frames you see outside the limb.
Yeah. Pins are drilled into the bone above and below the fracture, but outside the main injury zone, and then they're connected by external rods.
So it stabilizes things temporarily.
Right. It's a temporary measure. Minimizes further blood loss from the fracture site, allows the patient's overall condition to stabilize, and lets that massive soft tissue swelling start to come down before you plan the definitive internal fixation.
That timing, letting the swelling settle, seems really important, especially for, well, open fractures.
Oh, absolutely critical. An open fracture, the bone has broken through the skin, is a true surgical emergency.
Why emergency?
Because the fracture site is now grossly contaminated with bacteria from the outside environment. The risk of a deep bone infection, osteomyelitis, is incredibly high.
And there's a way to classify how bad these are, right?
Yes, the Gusteel-Anderson classification. It directly correlates the amount of soft tissue damage and contamination with the subsequent infection risk.
Can you break that down?
Sure. Type I is relatively low energy. The wound is small, less than a centimeter. Type 2 involves a wound between 2 and 10 centimeters. Moderate contamination, more soft tissue damage.
And type 3?
Type 3 is the worst. High energy, wound bigger than 10 centimeters, extensive muscle damage, devitalization, often heavy contamination like farmyard injuries or gunshot wounds. These have the highest infection rates.
So what's the immediate game plan for any open fracture?
It's a strict protocol. Immediate intravenous antibiotics started as soon as possible, then urgent surgical irrigation and debridement in the operating room.
Debridement meaning cleaning out all the dead tissue and contaminants.
Exactly. Washing out debris, cutting away any tissue that doesn't look viable. If the wound is heavily contaminated or the patient isn't stable, you'd probably place an external fixator initially.
And hold off on the plates and screws.
Yeah. Definitive internal fixation is delayed until you're confident the wound is clean and the soft tissues are healthy enough to tolerate more surgery.
How do you judge when the tissues are ready? Is there a sign?
Sometimes surgeons use the wrinkle test. If the skin around the injury is so swollen and tense that the normal skin wrinkles have disappeared, it's often considered too tight, too edematous to safely proceed with definitive fixation. You wait for the wrinkles to come back as the swelling subsides.
Makes sense. And covering that exposed bone quickly must be important too.
Paramount. Especially on the tibia, the shin bone, which has very little natural soft tissue padding over it. Large tibial wounds might need local muscle flaps rotated over to cover the bone.
And sometimes even more complex procedures.
For wounds in the distal third of the tibia, where local muscle isn't available, you might need a free flap-transferring tissue with its own blood supply from somewhere else on the body using microsurgery. It highlights how the soft tissue injury really dictates the whole treatment course.
And just to reiterate, the higher that Gusteel grade,
the higher the documented risk of infection. Aggressive early management is everything.
Okay, let's shift gears to another emergency where timing is absolutely critical. Compartment syndrome.
Yes, a true limb-threatening condition. It comes back to that pressure concept we touched on with splinting.
How does it happen?
Basically, swelling or bleeding occurs within a closed fascial compartment. These are tight, inelastic envelopes around muscle groups. The pressure inside builds up.
And that pressure does what?
It gets high enough to compromise blood flow at the microcirculation level, starving the muscles and nerves within that compartment of oxygen. This leads to ischemia and, if not treated, necrosis tissue death.
So how do you diagnose it? What are you looking for?
The single most important thing is a high index of suspicion. Don't wait for classic signs to fully develop.
What's the typical early complaint?
Pain that seems way out of proportion to the actual injury, or a patient whose need for pain medication is rapidly escalating. Those are big red flags.
What about physical findings?
Pain, obviously. Swelling, the limb might feel very tense or woody. And a key sign is severe pain when you passively stretch the muscles in the affected compartment. And it's absolutely crucial for you, the listener, to understand the timing here.
What do you mean?
The late findings, things like numbness, paralysis, or even weirdly the absence of a pulse, Peripherally, those mean irreversible damage is probably already happening or has happened.
You can't wait for those.
No, you absolutely cannot wait. By then, the game is likely lost for that muscle and nerve function.
What if the patient can't tell you they're in pain? Unconscious, maybe intubated.
That's where objective measurement is key. You need to measure the pressure directly inside the compartments using a special needle and pressure monitor.
And there's a specific threshold.
Yes. The diagnosis is generally made when the measured pressure within the compartment is within 30 millimeters of mercury of the patient's diastolic blood pressure. That pressure difference is too low to allow adequate blood flow.
Okay, so you've confirmed compartment syndrome. What now?
Emergent fasciotomy, immediately. This is a limb-saving operation.
What does it involve?
Making long surgical incisions through the skin and, crucially, through the tight fascia overlying each affected compartment to release the pressure.
And if you delay this?
Delay leads to irreversible necrosis of muscle and nerve. This results in severe, permanent functional loss, often leading to claw-like deformities known as Volkmann's ischemic contractures. It's devastating.
Wow. Okay, one more major trauma topic before we move regionally. Pelvic fractures. These sound immediately life-threatening.
They absolutely can be. These are usually the result of massive high-energy trauma, like car crashes or falls from height. The immediate danger is hemorrhage, massive bleeding.
Where does the bleeding come from?
Most commonly, it's venous bleeding from the extensive network of veins, the venous plexus, that lines the inside of the posterior pelvis. But you can also have arterial injuries, like tearing the superior gluteal artery near the sciatic notch.
So, first steps in the trauma bay.
Aggressive resuscitation, fluids, blood products, often initiating a massive transfusion protocol, typically a 1-to-1-to-1 ratio of packed red blood cells, fresh frozen plasma, and platelets, especially if the patient is unstable.
And how do you stop the bleeding from the pelvis itself?
The critical first-line maneuver is external compression or stabilization. Applying a pelvic binder, a specific device, or even just wrapping a sheet tightly around the patient's hips at the level of the greater trochanters and clamping it.
How does that help?
It mechanically reduces the fracture somewhat, but more importantly, it decreases the overall volume of the pelvic ring. This tamponades or squeezes off the venous bleeding. It's particularly effective for those open book type fractures, the anteroposterior compression injuries where the pelvis springs open.
And given where the pelvis is, other structures are at risk too.
Definitely. You have to be highly suspicious for associated bladder and urethral injuries.
How do you check for those?
If you see blood at the urethral midis, the opening of the urethra, that's a major warning sign. You need to perform a retrograde urethrogram, an X-ray study, where dye is injected into the urethra before you even think about putting in a Foley catheter.
Why? What happens if you just place the catheter?
If the urethra is torn, trying to force a catheter in the iter can convert a partial tear into a complete transection. Big problem.
Good point. And one last thing about the pelvis.
Yeah.
It's a ring, right?
Exactly. It's a ring structure.
Yeah.
If you find one fracture or point of ligamentous disruption, you absolutely have to look for a second injury somewhere else in the ring. It almost never breaks in just one place.
That focus on looking for associated injuries is a perfect transition as we move into regional trauma. Let's start up top with the shoulder girdle. Scapula fractures, for example. You don't see those every day.
No, and when you do, it usually means significant force was involved. High energy trauma.
And they often signal other problems.
Absolutely. The sources really emphasize this. Over a third of patients with scapula fractures have associated lung injuries like pneumothorax or pulmonary contusions. Other high-velocity injuries are common too.
But the scapula fracture itself, usually treated non-operatively.
Mostly, yes. Surgery is typically reserved only if the fracture significantly involves the glenoid, the socket joint surface, or if there's major displacement affecting shoulder mechanics.
Okay, now the shoulder joint itself is famous for popping out. Dislocations.
By far the most commonly dislocated large joint, and almost always they dislocate anteriorly towards the front.
And when that happens, there are specific associated injuries you have to look for.
Always. You need to check for a bony Bankart lesion that's a fracture of the front bottom edge of the glenoid rim, and a Hill-Sachs lesion, an impaction fracture, a dent on the back of the humeral head where it crashes against the glenoid rim during the dislocation.
Nerves at risk, too.
The axillary nerve is particularly vulnerable as it wraps around the surgical neck of the humerus. Always check for sensation over the deltoid patch and deltoid muscle function.
What about posterior dislocations? Going out the back.
Much less common, and importantly, often missed on initial x-rays.
Why are they missed?
They don't look as dramatic on the standard AP view. They're often associated with violent muscle contractions, think seizures or electric shocks. The key sign is a shoulder locked in internal rotation. If you see that, you must get an axillary view X-ray to diagnose it properly.
And recurrence, is that a big issue with shoulder dislocations?
Huge, especially in younger patients. The sources quote recurrence rates as high as 90% in patients under 20 years old after a first-time traumatic dislocation.
Wow. Okay, moving down the arm to the humerus itself. Proximal humerus fractures near the shoulder. Common in older folks after a fall.
Very common. We classify them using Nair's four-part system based on displacement of the key segments: the humeral head, the greater tuberosity, the lesser tuberosity, and the shaft.
And the big concern here is
Osteonecrosis, or vascular necrosis, of the humeral head. If the fracture displaces significantly, it can disrupt the blood supply to the head, causing it to die.
so if it's really badly broken up, especially in an elderly patient,
You might bypass trying to fix it altogether and go straight to a joint replacement, either a hemiarthroplasty, replacing just the ball, or a total shoulder replacement.
what about fractures further down in the shaft of the humerus?
Isolated humeral shaft fractures are different. The vast majority actually heal quite well without surgery, often just in a brace or cast.
But there's a nerve we need to worry about here.
The radial nerve, it spirals very closely around the humeral shaft in the spiral groove. So every single time you evaluate a humeral shaft fracture, you must check for wrist drop, the inability to extend the wrist and fingers.
And that indicates.
A radial nerve injury. Usually it's just a neuropraxia, a temporary stunning of the nerve, but you have to document it. There's even a specific named fracture pattern, the Holstein-Lewis fracture, a spiral fracture of the distal third that's particularly associated with radial nerve palsy.
Okay, let's focus on the elbow and forearm now. That seems like a complex area. Distal humerus fractures.
Very challenging. They go right into the elbow joint, they're often shattered, and the big enemy after treatment is stiffness. The elbow just loves to get stiff.
So the goal of treatment is?
Meticulous surgical fixation, usually with plates and screws, aiming for enough stability to allow early range of motion exercises. That's key to preventing debilitating joint contracture. In really severe cases in the elderly, sometimes a total elbow replacement is the best option.
What about elbow dislocations? We hear about the terrible triad.
Ah, yes, the terrible triad of the elbow. It's a specific, highly unstable injury pattern.
What makes up?
It consists of three things happening together: a posterior elbow dislocation, plus a fracture of the radial head, plus a fracture of the coronoid process of the ulna.
And why is that so bad?
Because it disrupts stability on both the medial and lateral sides of the elbow. It's inherently unstable and absolutely requires surgery to restore stability.
What does the surgery involve?
Usually repairing the lateral collateral ligament complex, fixing or replacing the fractured radial head, and fixing the coronoid fragment. It's complex reconstruction.
Okay, another common elbow fracture. The olecranon, the pointy bone at the back.
Right. Olecranon fractures almost always need surgery
Why is that?
because the powerful triceps muscle attaches there. When the bone breaks, the triceps pulls the fragment proximally, creating a gap that won't heal on its own. It's a deforming force.
So how do you fix it, typically?
For simple transverse fractures, the classic technique is a tension band construct. You use pins across the fracture and a figure-of-8 wire loop. When the elbow extends and the triceps pulls, the wire actually converts that distraction force into a compressive force across the fracture site. Clever biomechanics.
Any common issues after surgery?
Symptomatic hardware is pretty common. Because the olecranon is right under the skin, patients often feel the wires or pins, and they frequently need a second minor surgery later on just to remove the hardware once the fracture is healed.
Moving down into the forearm. Two bones, radius and ulna. Precision seems key here.
Absolutely essential. To preserve the crucial forearm motions of pronation, palm down, and supination, palm up, you have to restore the anatomy perfectly. That means restoring the natural curve or bow of the radius and its relationship with the straight ulna.
And there are specific fracture dislocation patterns to watch out for?
Yes, two classic ones you must recognize. The Montague fracture is a fracture of the ulna shaft associated with the dislocation of the radial head at the elbow.
Okay, ulna fracture, radial head dislocation. What's the other one?
The Galeazzi fracture. That's a fracture of the distal radius shaft associated with an injury or dislocation of the distal radial nar joint, the DRUJ, down at the wrist. Missing either of these associated dislocations leads to poor outcomes.
Speaking of the distal radius, those fractures are incredibly common, right? Wrist fractures.
Probably the most common fracture in the upper extremity, especially in older adults.
And we have names for the typical patterns.
The classic one is the collis fracture, usually extra-articular, with the distal fragment displaced dorsally towards the back of the hand, creating that characteristic dinner fork deformity.
And the opposite.
Is the Smith's fracture, where the distal fragment is displaced volarly towards the palm side.
When do these need surgery?
The main indications are instability, meaning it won't stay reduced in a cast, or if the fracture line extends into the wrist joint surface, the articular surface, you need that surface to be smooth.
All right, last stop in the upper limb. The wrist bones, specifically the scaphoid. This one has a bad reputation.
It does. Scaphoid fractures are notorious for being easily missed on initial x-rays.
And why is missing it such a problem?
Because the scaphoid has a tenuous blood supply, particularly to its proximal pole, the end closer to the forearm. The blood flows mostly retrograde from distal to proximal.
So a fracture, especially at the waist or proximal pole, can cut off that blood supply.
Exactly, leading to a high risk of the fragment not healing, non-union, or the bone dying from lack of blood, a vascular necrosis, or AVN.
How do you diagnose it if x-rays might be normal initially?
Clinical suspicion is key. Tenderness specifically in the anatomic snuff box. That little depression on the thumb side of the wrist when you extend your thumb should be treated as a scaphoid fracture until proven otherwise, usually with repeat x-rays or advanced imaging like MRI or CT.
Is there any sign later on that tells you if the bone still has blood supply?
Yes, Hawkins sign. It's a subtle finding on x-ray, a thin line of subchondral lucency, bone resorption, that appears about 6 weeks after the injury. Paradoxically, seeing this resorption means the bone fragment is vascular and trying to heal.
Okay, let's make a sharp pivot now to the spine, a region where stability and neurological function are everything.
Absolutely. Spinal trauma management starts the moment you suspect an injury. Assess stability, immobilize immediately, usually with a collar and backboard initially, and keep them immobilized until the full extent of the injury is understood.
How do you figure out the extent of the injury? Imaging.
Imaging strategies have really evolved. Nowadays, a computed tomography, a CT scan, is considered much more reliable than plain x-rays for looking at the detailed bony anatomy of the spine. It picks up fractures that plain films miss.
What about MRI?
MRI is crucial in certain situations. If a patient has known ankylosing spondylitis, their spine is already fused and brittle. They can have subtle fractures that CT misses. Also, if the patient is unconscious or neurologically impaired, an MRI is needed to look for occult fractures, ligament injuries, or epidural bleeding compressing the cord.
And if there is a spinal cord injury?
Management is complex, obviously differentiating between complete and incomplete injuries, but a key finding from the literature is that outcomes, specifically in terms of reducing permanent paralysis, are significantly better when these patients are triaged directly to specialized trauma centers with spinal cord injury expertise.
And if there's neurological deficit or the cord is being compressed?
Then surgical decompression is indicated to relieve that pressure.
Okay, let's talk specific cervical spine injuries. High up in the neck, occipital cervical dislocation.
That's a separation between the skull, occiput, and the first cervical vertebra, C1. It's a devastating, highly unstable injury, often fatal. If the patient survives, it requires surgical fusion. Importantly, traction is absolutely contraindicated. It would pull things further apart.
What about C1 itself, the atlas?
Fractures of C1 are often called Jefferson fractures. They typically result from an axial load, like diving into shallow water. Stability depends entirely on the integrity of the transverse ligament, which holds the dens, the peg from C2, against C1.
How do you assess that ligament?
On imaging, you look at the atlanodens interval, the ADI. If that space is greater than 3 millimeters in an adult, the transverse ligament is likely ruptured, making the injury unstable and usually requiring fusion or halo immobilization.
Moving down to C2, the axis, the odontoid process, that peg.
Odontoid fractures are common and classified based on location. Type 1 is rare at the tip. Type 3 goes into the body of C2 and usually heals well.
But type 2?
Type 2 is the problematic one. It's a fracture right at the base of the dens. It has a very high risk of not healing, non-union risk, sometimes quoted as high as 80%, especially if displaced. It generally requires surgical stabilization.
And how do you fix it?
Often with an anterior screw placed up through the body of C2 into the dens fragment. The advantage of screw fixation over a posterior C1-C2 fusion is that it preserves a significant amount of neck rotation, up to 50%, which is lost with fusion.
Well, it was a hangman's fracture. Sounds ominous.
It's actually a fracture through both pars interarticularis, the bony struts at the back of C2. It's typically caused by hyperextension, like in a judicial hanging, hence the name. Paradoxically, despite sounding severe, it often doesn't cause major neurological injury because the canal actually widens at that level.
Okay, burst fractures. We hear that term a lot.
Burst fractures occur typically from a significant axial load, causing the vertebral body to literally burst or explode. The danger is that bony fragments are displaced backwards or retropulsed into the spinal canal, potentially compressing the spinal cord or nerves.
How are they treated?
Unstable burst fractures, or those causing neurological symptoms, usually require surgery. Often an anterior approach is needed to remove the vertebral body, orthopectomy, decompress the canal, and then reconstruct the spine with a cage and plate or rods.
What about injuries from flexion and distraction, like hitting the dashboard?
That mechanism causes unilateral or bilateral facet dislocations. The facets are the small joints at the back of the vertebrae that guide motion. In this injury, the upper vertebra slides forward on the lower one.
How bad is that?
Bilateral facet dislocation, where both sides are jumped forward by more than 50% of the vertebral body width, is extremely unstable and carries a very high risk of severe spinal cord injury. Unilateral is less severe, but still unstable.
Can you reduce these without surgery?
Yes, closed reduction is often attempted, but it has to be done carefully with the patient awake, using cranial tongs and gradually adding weight to distract and realign the spine.
What if the patient is unconscious?
This is a critical point. If the patient is unconscious or can't cooperate, you must get an MRI before attempting reduction.
Why?
Because there's a high incidence of associated traumatic disc herniation with these injuries. If you try to pull the spine back into alignment over a large herniated disc, you can literally guillotine the spinal cord. The MRI rules that out first.
Scary thought. Okay, moving down to the thoracic and lumbar spine. Any key differences?
The thoracic spine is inherently more stable because of the rib cage acting like a scaffold. However, the spinal canal is narrower there. Meaning neurologic injuries, if they occur, tend to be more severe and complete in the thoracic and thoracolumbar junction area around T12-L1 because there's less room for the spinal cord, which ends around L1 or L2.
We talked about burst fractures. How do they differ from simple compression fractures?
The key differentiator is involvement of the posterior cortex of the vertebral body, the middle column. A simple compression fracture involves only the anterior part squashing down. A burst fracture involves failure of that posterior wall, allowing fragments into the canal.
Any signs on X-ray to look for?
On the front view, the AP view, look for widening of the distance between the pedicles that suggests the posterior elements have been pushed apart, indicating instability. And on the side view, look for that retropulsion of bone into the canal.
Treatment difference.
Unstable burst fractures or those with neurodeficits need surgery. Simple stable compression fractures are often treated non-operatively in a brace.
What about seatbelt injuries?
These are classic flexion distraction injuries, sometimes called chance fractures. The lap belt acts as a fulcrum, and the spine is literally pulled apart from back to front, often involving unstable tears of the posterior ligaments and sometimes a fracture through the bone.
And associated injuries.
Yes, particularly in children, these carry a high risk of associated intra-abdominal injuries, like bowel or colon perforation, because of the force concentrated by the seatbelt. They almost always require surgical stabilization, usually with posterior instrumentation infusion.
All right, let's touch on some common spinal pathology, not necessarily trauma. Disc herniations.
Very common cause of back and leg pain or neck and arm pain. The good news is that the vast majority, maybe 80–90%, of symptoms resolve on their own within about 6 to 8 weeks with conservative care.
When is surgery considered?
For persistent disabling symptoms that don't improve, or for progressive neurological deficits like weakness.
And the surgical approach depends on location.
Yes. In the neck, cervical spine, the standard approach is usually anterior from the front, removing the disc and fusing the vertebrae, ACDF. For most lumbar disc herniations causing sciatica, a posterior approach, like a microdiscectomy, is used.
Any exceptions?
A posterior approach is generally avoided for disc herniations in the thoracic spine because the spinal cord is very sensitive there and the canal is tight.
Now, you mentioned emergencies earlier. Is there an emergency related to disc herniation?
Absolutely. Cauda equina syndrome. This is a true orthopedic and neurosurgical emergency.
What causes it?
Usually a massive central disc herniation or sometimes a tumor or epidural access that compresses the bundle of nerve roots at the bottom of the spinal canal, the cauda equina, which looks like a horse's tail.
What are the symptoms?
The red flags are severe low back pain, often bilateral leg pain or weakness, saddle anesthesia, numbness in the perineal area, groin, buttocks, and critically, difficulty with bladder or bowel function, retention or incontinence.
And treatment.
Urgent surgical decompression. Delay in treatment can result in permanent paralysis, incontinence, and sexual dysfunction. Time is critical.
Okay, last spine topic. Spinal stenosis. Narrowing of the canal.
Right. Usually happens gradually with age due to degenerative changes, bulging discs losing height and water content, thickening of the ligamentum flavum at the back of the canal.
How does it present differently in the neck versus the low back?
Cervical stenosis causes myelopathy symptoms of spinal cord compression, like clumsiness, loss of fine motor skills in the hands, difficulty walking, hyperreflexia, gait disturbance.
And lumbar stenosis.
Causes neurogenic claudication. This is pain, numbness, or weakness in the legs that is specifically brought on by standing or walking, spinal extension, and relieved by sitting or bending forward, spinal flexion.
Ah, the classic shopping cart posture.
Exactly. Patients find relief leaning over a shopping cart because it flexes the lumbar spine, opening up the canal space a bit. That posture preference is the key clinical clue differentiating it from vascular claudication, which is related to blood flow and usually relieved just by stopping activity, regardless of posture.
Okay, let's move down to the lower extremity, starting with probably one of the most feared injuries in orthopedics, knee dislocations.
Absolutely limb-threatening, not just the bony injury, but the high risk to the blood supply.
Which vessel is at risk?
The popliteal artery. It runs right behind the knee joint and is tethered proximally and distally, making it very susceptible to stretching, tearing, or getting trapped when the knee dislocates.
So, immediate management.
Urgent reduction of the dislocation first. Then, a meticulous neurovascular exam. Check pulses carefully. And then calculate the ankle brachial index, the ABI.
Remind us what the ABI is.
It's the ratio of the systolic blood pressure measured at the ankle to the systolic pressure measured in the arm. A simple bedside test.
And the number tells you what?
A normal ABI is typically 1.0 or slightly higher. If the ABI is greater than 0.9 after reduction, the standard is usually close observation and serial exams.
But if it's low?
If the ABI is less than 0.9, even if you feel a pulse, it indicates compromised flow. A CT angiogram or arterial duplex ultrasound is mandatory to evaluate the artery.
And if there's no pulse at all after reduction?
That's an immediate surgical emergency. No time for further imaging. The patient needs immediate surgical exploration and repair by a vascular surgeon.
Time is critical here, isn't it?
Extremely. Ischemia time, the time the limb is without adequate blood flow, is the biggest predictor of outcome. More than about 8 hours of warm ischemia time dramatically increases the risk of needing an amputation.
What about the ligaments? They must be torn too.
Oh yeah. Knee dislocations usually involve tearing multiple ligaments. But the definitive multiligamentous reconstruction is always delayed. You deal with the vascular emergency first, let the soft tissues recover, and then plan the complex ligament surgery weeks or months later.
Okay, sticking with the knee, what about injuries to the extensor mechanism?
That's the quadriceps tendon, the patella kneecap itself, and the patellar ligament below it. They all work together to straighten the knee.
What's a key sign of injury here?
The inability to actively extend the knee against gravity. If the patient can't lift their straight leg off the bed, the extensor mechanism is disrupted.
And treatment?
These injuries require surgery to restore function. Tendon ruptures need direct suture repair. Patella fractures often need fixation, maybe with tension band wiring, like the olecranon.
Patella dislocations are common too, right? Usually lateral.
Yes, the patella typically dislocates laterally towards the outside of the knee. Often it reduces spontaneously before the patient even gets to the ER. The main ligament torn or stretched is the medial patellofemoral ligament, the MPFL, which is the primary restraint against lateral dislocation.
Now, fractures into the knee joint. Tibial plateau fractures.
These happen from axial loads, often combined with a sideways force, valgus or varus. Think of a car bumper hitting the side of the knee. They frequently damage the menisci and articular cartilage as well.
Is there a classification?
Yes, the SCHWARTZ classification, types I through 6, describes the different fracture patterns based on which plateau, lateral or medial, is involved and the degree of depression or splitting.
Any particular type to be wary of?
SCHWARTZ type 4, a medial plateau fracture, can sometimes be associated with vascular injury, almost like a variant of a knee dislocation. So again, checking that ABI is important.
Treatment goal.
Anatomic restoration of the joint surface is critical to minimize post-traumatic arthritis. This often requires not just plates and screws, but also bone graft or a synthetic bone graft substitute like calcium phosphate packed underneath the depressed fragments to buttress them up and support the articular surface.
Moving further down the tibia to the ankle joint surface, tibial plafond or pylon fractures.
These are bad news. High-energy axial compression injuries like a fall from a height landing on the feet driving the talus up into the distal tibial articular surface, the plafond.
What characterizes them?
Massive articular comminution, shattering, and usually very significant soft tissue injury and swelling.
So immediate surgery's out.
Often, yes. Similar to other high-energy injuries with massive swelling, treatment is usually delayed. Often, an external fixator is applied initially spanning the ankle joint to maintain length and alignment while the swelling subsides. Again, you wait for that positive wrinkle test.
And the long-term outcome.
Even with excellent surgical restoration of the joint surface, these injuries have a high rate of complications, including stiffness, pain, and post-traumatic arthritis, frequently leading to ankle fusion down the road despite best efforts. The initial injury severity is just too high.
Okay, let's talk about more common ankle fractures. What's the overarching goal?
Precise restoration of the ankle mortise anatomy. This means getting the fibula back to its correct length and rotation relative to the tibia and ensuring the talus sits perfectly centered underneath the tibial plafond.
Why is that precision so critical?
Because of this key fact, just 1 millimeter of lateral shift of the talus within the mortise decreases the contact surface area between the talus and the tibia by about 40%.
Wow, 40% from just 1 millimeter.
Yeah. And that dramatically increases the contact stress on the remaining cartilage, massively accelerating the development of post-traumatic arthritis. That's why surgeons are so meticulous about anatomic reduction.
What about the ligaments holding the tibia and fibula together at the ankle?
Yeah.
The syndesmosis.
Injury to the syndesmotic ligaments, creating instability between the distal tibia and fibula, is common with certain ankle fracture patterns.
How do you diagnose widening?
Often it's diagnosed intraoperatively. After fixing the bone fractures, the surgeon performs an external rotation stress test under fluoroscopy, live X-ray. If the space between the tibia and fibula widens abnormally, the syndesmosis is unstable.
And how is it fixed?
Typically with 1 or 2 screws going from the fibula across into the tibia, holding the two bones in the correct relationship while the ligaments heal. These screws are often removed later, maybe 3-6 months down the line, to restore normal ankle mechanics.
Is there a fracture pattern where syndesmotic injury is basically guaranteed?
Yes, the Maisonneuve fracture. You absolutely have to know this one.
What is it?
It's a fracture of the proximal fibula, way up near the knee, that occurs in association with either a medial malleolus fracture down at the ankle or a tear of the deltoid ligament on the medial side.
So proximal fibula break plus medial ankle injury.
Always means the force transmitted up the interosseous membrane and disrupted the syndesmosis as well. Therefore, a Maisonneuve fracture always requires fixation of the syndesmosis down at the ankle. Even though the fibula fracture itself is way up high, you have to examine the entire fibula in any ankle injury.
Good point. Moving to the heel bone, calcaneal fractures.
Usually from a fall from height. Always remember to check for associated injuries, particularly lumbar spine compression fractures, as the force transmits up the body.
Any other acute concerns?
High incidence of foot compartment syndrome with calcaneal fractures due to the bleeding and swelling in a tight space. You have to watch for that. Radiographically, you look for flattening of Boulder's angle, which indicates collapse of the heel bone's height.
And the outcome?
Unfortunately, often depends heavily on how badly shattered the bone is, the degree of comminution. The more fragments, generally the worse the long-term outcome regarding pain and subtalar joint arthritis.
What about the talus, the bone sitting between the calcaneus and the tibia fibula?
Talus fractures, especially of the talar neck, often happen from forced hyperdorsiflexion, like slamming on the brakes in a car crash.
Big concern here is blood supply again.
Yes, very much so. The talus has a precarious, largely retrograde blood supply, similar to the scaphoid. Displaced taloneck fractures have a very high risk of interrupting this supply, leading to osteonecrosis, AVN, of the talar body. The risk ranges from maybe 15% for minimally displaced fractures up to nearly 100% for severely displaced fracture dislocations.
Any specific complication to avoid during treatment?
Varus malunion. If the talar neck heals tilted inwards in varus, it significantly blocks subtalar joint eversion, outward motion of the heel, and forces the patient to walk with an internal rotation gait. It's a preventable complication with careful reduction and fixation.
Okay, last stop in trauma. Foot fractures. Anything specific to highlight?
Lisfranc injuries are crucial. These are injuries to the tarsometatarsal joint complex, essentially the midfoot. They can range from subtle sprains to frank fracture dislocations.
Why are they important?
Because midfoot instability, even subtle instability, is highly prone to leading to debilitating post-traumatic arthritis. Diagnosis requires weight-bearing x-rays or stress views. Treatment requires either perfect anatomic reduction and fixation, or for purely ligamentous injuries where healing is unreliable, consideration of a primary arthrodesis fusion of the affected joints.
Any other specific foot fracture?
The Jones fracture. This is a fracture of the fifth metatarsal, the bone leading to the little toe, specifically at the metaphyseal-diaphyseal junction. It occurs in a watershed area of blood supply and has a significant risk of non-union, especially in athletes. Often requires screw fixation for reliable healing.
All right, let's shift gears into sports medicine. Here we're often dealing less with outright bone breaks and more with dynamic stability and soft tissue problems, right?
Exactly. Starting with the shoulder again, but focusing on the rotator cuff.
These are the tendons that help lift and rotate the arm.
Correct. Injuries here are very common, often associated with repetitive overhead activities like throwing, swimming, or occupations involving heavy pulling.
How has treatment changed?
Outcomes have definitely improved with the widespread adoption of arthroscopic techniques. Less invasive surgery often leads to faster recovery and less pain compared to the older open repairs.
But rehabilitation is key, isn't it? There's a strict protocol.
Absolutely critical. You can have a technically perfect repair, but if the rehab isn't done right, it can fail. The timeline is generally quite protected.
Can you outline that?
It usually starts with a period of immobilization, often in a sling, for maybe 4 to 6 weeks. During this time, only passive range of motion is allowed, meaning the therapist moves the arm, the patient doesn't actively lift it.
Then what?
Then you gradually progress to active assisted and then active range of motion. Strengthening exercises typically don't start until around 8 to 12 weeks post-op, sometimes even later depending on the tear size and repair quality.
So you really can't rush it.
Trying to rush it is a recipe for re-tear. Patience is vital.
Okay, another shoulder issue in athletes. SLAP lesions. What are those?
SLP stands for superior labrum anterior and posterior. It's a tear of the labrum, the cartilage rim around the glenoid socket, specifically at the top where the long head of the biceps tendon attaches.
What causes them?
Can be from acute trauma, like a fall onto an outstretched arm, or more commonly from repetitive overhead motion, especially in throwing athletes.
Hard to diagnose.
Can be tricky clinically. Diagnosis is often enhanced by getting an MRI with a gadolinium arthrogram injecting dye into the joint, which helps highlight the tear better than a standard MRI.
What about impingement syndromes? That feels like a catch-all term.
It kind of is. It describes irritation or pinching of the rotator cuff tendons and the bursa as they pass through the narrow subacromial space underneath the acromion bone.
What causes the pinching?
Could be simple bursitis or tendinitis initially, but over time, chronic impingement can lead to fraying and eventual tearing of the supraspinatus tendon, the uppermost rotator cuff tendon. Bone spurs on the underside of the acromion can contribute too.
Treatment approach.
Initial treatment is almost always conservative. Rest, activity modification, NSAIDs, physical therapy focusing on posture and rotator cuff strengthening, and maybe a targeted subacromial corticosteroid injection.
And if that fails?
Then surgery might be considered. The goal is usually to create more space for the tendons. This involves a subacromial decompression, which includes removing the inflamed bursa, bursectomy, and sometimes shaving down the undersurface of the acromion, acromioplasty. If there's a significant tear, that gets repaired too.
Okay, let's move down to the knee again, focusing on the soft tissues critical for athletes, the menisci.
The menisci, those two C-shaped pieces of cartilage between the femur and tibia are incredibly important. They act as shock absorbers, improve joint stability, and help distribute load across the articular cartilage.
And the thinking on treating tears has changed drastically, hasn't it?
Dramatically. The old paradigm was often just to remove the torn part, a partial meniscectomy. It provided quick symptom relief.
But the new thinking.
The modern paradigm is all about meniscal preservation whenever possible. This means trying to repair the meniscus rather than remove it. Techniques like meniscal root repair, reattaching it to the bone, and even meniscal transplantation are being used more.
Why the big shift? What did we learn?
We learned through long-term studies that removing even part of the meniscus significantly alters knee biomechanics and dramatically increases the contact stress on the articular cartilage,
Leading to?
leading directly to accelerated joint wear and the early onset of severe osteoarthritis. So, saving the meniscus, even if the rehab is longer after a repair, is really an investment in the long-term health of the knee. It's preventative medicine.
Makes sense. What about the collateral ligaments on the sides of the knee?
The medial collateral ligament, or MCL, on the inner side is the most frequently injured knee ligament, usually from a valgus force getting hit on the outside of the knee.
Does it heal well?
Generally, yes. The MCL has excellent healing potential. Grade 1, sprain, and Grade 2, partial tear injuries are almost always treated conservatively with bracing and physical therapy. Even most isolated Grade 3, complete tears, can often be managed non-operatively, unless they avulse off the tibial side or are part of a multi-ligament injury.
Now for the big ones inside the knee. The cruciate ligaments, ACL and PCL.
Right, the anterior cruciate ligament, ACL, and posterior cruciate ligament, PCL, are the primary stabilizers against front-to-back translation and rotation.
ACL tears are incredibly common in sports.
Mm.
Do they heal on their own?
Famously, no. The ACL tears within the joint in synovial fluid and just doesn't have the biological environment to heal itself.
So surgery is usually the answer.
For young active patients who want to return to cutting, pivoting sports, ACL reconstruction is typically the treatment of choice. The goal is to restore normal knee kinematics and hopefully prevent or delay the onset of degenerative changes that often follow an ACL tear, even with reconstruction.
There's always debate about the graft choice for reconstruction, isn't there?
Always. The main options are autograft, using the patient's own tissue, like patellar tendon or hamstring tendons, or allograft, using donor tissue.
Pros and cons.
Autografts generally have better biological healing potential and possibly lower re-tear rates, but they involve harvesting tissue from the patient, which causes donor site morbidity, pain, weakness. Allografts avoid donor site morbidity, but might have slightly higher failure rates and a theoretical, though extremely low, risk of disease transmission. Graft choice is often tailored to the patient's age, activity level, and surgeon preference.
What's the best way to test for an ACL tear clinically?
The Lachman's test is generally considered the most sensitive and specific clinical examination test for diagnosing an ACL tear.
Okay, what about the PCL, posterior cruciate ligament?
PCL tears are much less common than ACL tears, often resulting from a direct blow to the front of the tibia, like hitting the dashboard, or a fall onto a flexed knee.
How do they do?
Isolated PCL tears, especially lower grade ones, grade 1 or 2, are often surprisingly well tolerated and can frequently heal with non-operative management, focusing on quadriceps strengthening.
When is surgery needed?
Surgery is usually reserved for high-grade, grade 3 tears, especially if they're combined with other ligament injuries or if the patient has persistent instability symptoms despite rehab. PCL reconstruction is technically demanding.
Why demanding?
Techniques like transtibial drilling a tunnel through the tibia from front to back, can create a sharp turn for the graft, the so-called killer turn, which can lead to graft abrasion and failure. Tibial inlay techniques, fixing the graft directly onto the back of the tibia, aim to avoid this but require a posterior approach.
Before we leave the knee, there's one area you stressed is often missed, the posterolateral corner.
Yes, the PLC. This is a complex area on the outside back of the knee containing critical stabilizing structures.
Like what?
The main static stabilizers are the lateral collateral ligament, LCL, the popliteus tendon, and the popliteofibular ligament. They work together to resist varus, sideways opening, and external rotation forces.
Why is recognizing injury here so important?
Because an untreated or missed PLC injury leads to persistent instability, particularly rotational instability. And crucially, a deficient PLC is a major documented cause of failure after an ACL or PCL reconstruction. If you don't fix the PLC instability, the cruciate graft will likely stretch out or fail over time.
So how should PLC injuries be managed?
Acute injuries, recognized within the first 2-3 weeks, should ideally be repaired directly. Chronic PLC instability usually requires a complex reconstruction using graft tissue. The mastery lies in suspecting it, diagnosing it accurately, often requiring stress X-rays or MRI, and addressing it appropriately, often at the same time as any cruciate ligament surgery.
All right, let's transition to joint reconstruction, primarily dealing with the consequences of arthritis. First, the sheer scale of the problem is staggering, isn't it?
It really is. The sources cite figures like 55 million U.S. adults currently diagnosed with some form of arthritis.
And that number is projected to climb significantly.
Yeah, projected to hit something like 67 million by 2030. The major driving factors are simply the aging population and the ongoing obesity epidemic. Age and weight are huge risk factors.
How does diagnosis typically start? Just listening to the patient.
Often, yes. History is key. Where does it hurt? Groin pain, for example, almost always points towards hip joint arthritis itself. Pain over the side of the hip, the greater trochanter area, is much more likely to be trochanteric bursitis. Listening localizes the problem.
What about observing how they walk? Gait.
Very important. A Trendelenburg gait, where the pelvis drops on the opposite side when weight-bearing, indicates weakness of the hip abductor muscles, gluteus medius and minimus. This can be from the arthritis itself causing pain inhibition, or sometimes from previous surgery or nerve issues.
Before jumping to surgery, what are the essential non-operative steps?
They form the foundation of treatment. Weight loss is paramount. Physical therapy to maintain range of motion and strength. Non-steroidal anti-inflammatory drugs, NSAIDs, for pain and inflammation. Sometimes bracing, particularly for knee arthritis.
You mentioned weight loss. Is there data on how much difference it makes?
There's a striking statistic quoted. For women, losing just 11 pounds, about 5 kilograms, can decrease the risk of developing symptomatic knee osteoarthritis by 50%.
50%. That's huge.
It really highlights the impact of mechanical load on joint health. Even simple assistive devices help. Using a cane.
Which hand should you hold it in?
You hold the cane in the hand opposite the painful hip or knee. This helps shift the body's center of gravity and significantly reduces the load across the affected joint, thereby reducing pain.
What about injections, cortisone shots?
Corticosteroid injections can be very useful, both diagnostically, if the pain goes away, you inject the right spot, and therapeutically for temporary relief. You do need to be aware they can cause a temporary spike in blood sugar in diabetic patients.
What about the other common injection, hyaluronic acid or viscosupplementation, gel shots?
Their role is much more controversial. The exact mechanism isn't fully understood, and major orthopedic bodies like the American Academy of Orthopaedic Surgeons, AAOS, have questioned their efficacy based on large-scale reviews. Some patients report benefit, but the evidence is mixed.
Okay, so when non-operative measures aren't enough, what are the main surgical strategies?
There are a few broad categories. Osteotomy is one.
What does that involve?
Osteotomy means cutting the bone and changing its position or alignment. The goal is usually to shift the weight-bearing forces away from a damaged area of the joint onto a healthier area.
Can you give an example?
A classic example is a high tibial osteotomy, HTO, for a younger, active patient with medial compartment knee osteoarthritis and a varus bow-legged deformity. By cutting the tibia and tilting it slightly outwards, you offload the worn-out inner part of the knee. Pelvic osteotomies are also used in younger patients for hip dysplasia.
Another option is arthrodesis or fusion.
Right. Fusion involves surgically removing the remaining articular cartilage from the joint surfaces and getting the bones on either side to heal together into one solid bone.
So, no more joint motion. When is that used?
It's typically reserved for severe arthritis in certain joints, particularly the ankle or wrist, or as a salvage procedure after failed joint replacement or infection. It can also be a primary option in very young, heavy laborers who need ultimate durability, accepting the loss of motion. It's often considered a last resort for joints like the hip or knee, but sometimes it's the best solution for severe ankle arthritis.
And the most common surgical solution? Arthroplasty, joint replacement.
By far the most common and widely considered one of the most successful and life-improving surgical procedures ever developed.
It can be total or partial.
Exactly. Total replacement means replacing all bearing surfaces of the joint. I example both femoral head and acetabulum in the hip, femur, tibia, and patella in the knee. Hemiarthroplasty means replacing only one side, for example, just the femoral head. Unicompartmental replacement means replacing just one compartment of the knee, for example, just the medial side.
Let's dive into total hip arthroplasty, or THA. Its success really hinges on some key principles, doesn't it?
Absolutely. Modern THA success owes a huge debt to Sir John Charnley. He established the core principles back in the 1960s.
Which were?
Using a low-friction articulation, metal on polyethylene originally, medializing the center of rotation of the hip joint, which reduces the forces across the joint, and critically, meticulously restoring the appropriate leg length and tensioning the abductor muscles to optimize function.
That abductor tension is key for gait.
Crucial for preventing that Trendelenburg limp and restoring a normal walking pattern. Leg length equality is also vital for patient satisfaction.
There are different surgical approaches to get the implants in. What are the main ones and their trade-offs?
The two most common are the direct anterior approach and the posterior approach.
Tell us about the anterior approach.
The anterior approach goes between muscle planes, typically between the sartorius densor fascia latae laterally and the rectus femoris gluteus medius medially. It's an internervous plane for much of the dissection.
What are its touted benefits?
Often cited benefits include the patient lying supine on their back, potentially less muscle cutting, though this is debated, and maybe slightly faster early ambulation in some studies, though long-term outcomes are generally equivalent.
What are the downsides?
It can be more technically demanding, especially getting good exposure of the femur, which can increase the risk of undersizing the femoral component or even intraoperative femur fracture. There's also a risk to the lateral femoral cutaneous nerve, causing thigh numbness. Revision surgery through an anterior approach can also be more difficult.
Okay, what about the posterior approach? Coker-Langenbach.
The posterior approach is more of a muscle-splitting approach. You split the fibers of the gluteus maximus and detach some or all of the short external rotator tendons from the back of the femur to access the joint.
Advantages?
Generally provides excellent extensile exposure of both the acetabulum socket and the femur, making it very versatile for both primary and complex revision surgeries.
Disadvantages. Historically, dislocation risk.
Historically, the posterior approach was associated with a slightly higher risk of dislocation. However, modern techniques emphasize meticulous repair of the posterior soft tissue capsule and the short external rotator tendons back to the bone at the end of the case. With a good repair, the sources suggest dislocation rates are now comparable between anterior and posterior approaches, often less than 0.5%.
That's a really low rate now. What about minimally invasive surgery, MIS, smaller incisions? Is that better?
This is a really important point synthesized from the sources. The only consistently documented benefit of MIS techniques in hip replacement is literally a smaller skin incision.
No other proven benefits.
No proven benefits in terms of less pain, faster recovery, or better long-term function. And importantly, MIS approaches are associated with potential risks. Decreased visualization for the surgeon, which can lead to a higher risk of component malposition, putting the parts in incorrectly, intraoperative fracture, and nerve or vascular injury. The trade-off for a smaller scar might not be worth these potential downsides. Good exposure is key to doing the operation correctly.
Makes sense. What about the parts themselves? The bearing surfaces, what rubs against what?
That's crucial for longevity. The most common bearing couple today is either metal or ceramic for the femoral head, articulating against a highly cross-linked polyethylene liner in the acetabular cup.
What about metal on metal? That was popular for a while.
Metal on metal, MOM bearings, have been largely abandoned. While they offered potentially lower wear rates initially, they were found to release metal ions, cobalt and chromium, into the bloodstream and surrounding tissues.
Causing what problems?
This led to adverse local tissue reactions, including pseudotumors, inflammatory masses around the hip, tissue necrosis, and high rates of early failure requiring revision surgery. A major issue.
What about ceramic on ceramic?
Ceramic on ceramic offers the lowest friction and lowest wear rates, potentially lasting the longest. The main drawbacks are a small risk of the ceramic fracturing, though modern ceramics are much tougher, and occasional reports of audible squeaking with certain activities.
So, if metal on metal is out, and ceramic has pros and cons, metal ceramic on polyethylene is the workhorse. But polyethylene still wears, right?
Yes, even the modern highly cross-linked polyethylenes still produce microscopic wear particles over time. And it's these wear particles, along with potentially particles from the bone cement, PMM if used, that are the primary enemy of long-term implant survival.
How do these tiny particles cause problems?
They trigger a biological reaction called osteolysis. The body's immune system sees these particles as foreign invaders. Macrophages try to engulf them, releasing inflammatory cytokines.
And these cytokines?
They activate osteoclasts, the cells that normally resorb bone. These osteoclasts start eating away the bone right around the implant, loosening the bond between the implant and the bone.
And that leads to loosening.
Exactly. Aseptic loosening, meaning loosening not caused by infection, driven purely by this biological response to wear debris. It's the most common reason for late failure of hip and knee replacements, necessitating complex revision surgery.
Okay, let's quickly touch on total knee arthroplasty, TKA, standard surgical approach.
Usually a medial parapatellar approach, going along the inner side of the kneecap.
Big debate here. Keep the PCL or sacrifice it. Cruciate retaining versus posterior stabilized.
Yes, cruciate retaining CR designs keep the patient's own PCL, while posterior stabilized PS designs remove the PCL and substitute its function with a built-in post-and-cam mechanism in the implants.
Which was better?
Decades of research and countless studies show essentially equivalent long-term functional results and survival rates between CR and PS designs when implanted correctly. Surgeon preference and experience often dictate the choice.
What about technology in TKA? Computer navigation, robotics. Are they making a difference?
This is another key synthesis point from the sources, mirroring the MIS finding in hips. These technologies are effective at minimizing alignment outliers. They help the surgeon place the components more consistently in the desired alignment.
But does that translate to better outcomes for the patient?
Here's the crucial finding. Despite improving alignment consistency, there is currently no proven benefit from computer navigation or robotics in terms of improved long-term implant survival or improved patient-reported functional outcomes compared to well-performed conventional knee replacement using standard instruments.
Interesting. So the mastery still seems to lie with the surgeon's skill and judgment, not just the tech.
It appears so, at least based on current long-term evidence. Good technique remains paramount. Okay, shifting into a different realm now, orthopedic pathology and oncology, dealing with tumors of the musculoskeletal system. Diagnosis starts, as always, with history.
Any specific red flags in the history for malignancy?
Yes. Pain that is unrelated to activity, or pain that is worse at night and interferes with sleep. Those are classic warning signs for a potential tumor, rather than a mechanical issue. Also, unexplained swelling or a palpable mass.
Does the patient's age help narrow things down?
Immensely. The age and gender of the patient are critical filters in the differential diagnosis. For example, a destructive bone lesion in a 10-year-old is statistically likely to be something like Ewing sarcoma or osteosarcoma. The same lesion in a 60-year-old makes you think first of metastatic disease or multiple myeloma.
What about imaging? X-rays.
Radiographic assessment is fundamental. Experts recommend asking 4 key questions when looking at a potential bone tumor on X-ray.
What are they?
1. Location, which bone is it in, and where within that bone? Epiphysis, metaphysis, diaphysis. 2. Behavior, what is the tumor doing to the bone? Is it destroying it? Epithelitic. Is it causing bone formation? Sclerotic. 3. Host response. What is the bone doing in reaction to the tumor? Is there a sharp margin? Is there periosteal reaction, new bone forming on the surface? 4. Matrix pattern. Can you see evidence of what the tumor cells are producing? EVG, fluffy, cloud-like bone matrix in osteosarcoma, or popcorn-like calcification in chondrosarcoma.
Okay, let's talk specific malignancies. Osteosarcoma.
The most common primary malignant bone tumor, excluding myeloma, typically affects adolescents and young adults, often around the knee, distal femur, or proximal tibia.
How aggressive is it?
Usually high-grade, growing within the medullary canal, intramedullary osteosarcoma. It has a high propensity to metastasize, primarily to the lungs. You also have to look for skip lesions, secondary tumor deposits elsewhere in the same bone.
Treatment strategy.
It's aggressive and multimodal. Typically involves preoperative neoadjuvant chemotherapy to shrink the tumor and treat micrometastases, followed by wide surgical resection, removing the tumor with a cuff of surrounding healthy tissue, and then post-operative adjuvant chemotherapy. Limb salvage surgery is now possible in most cases, avoiding amputation.
Are there less aggressive types?
Yes, there are lower-grade variants like peristeal osteosarcoma, which grows on the surface of the bone, often on the posterior distal femur. This type has a much better prognosis, with survival rates around 95%.
Second most common, Ewing sarcoma.
Right. Second most common, primary bone malignancy in patients under 25. Often occurs in the diaphysis shaft of long bones, like the femur.
Key features.
It's known for the characteristic T1122 chromosomal translocation. Radiographically, it often shows a permeative, moth-eaten pattern of bone destruction and a layered onion skin periosteal reaction.
Can it be mistaken for something else?
Yes, clinically, Ewing's can mimic an infection, osteomyelitis. Patients can present with pain, fever, swelling, and elevated inflammatory markers like ESR and white blood cell count, which can delay the correct diagnosis if not considered. Treatment also involves chemotherapy and surgery, sometimes radiation.
Third most common, chondrosarcoma.
This is a malignant tumor of cartilage cells. Typically affects older adults, usually males over 40. Common locations include the pelvis, shoulder girdle, and ribs.
What's the crucial point about treating chondrosarcoma?
Treatment is surgical excision only. Chondrosarcomas are generally not sensitive to chemotherapy or radiation therapy. Wide surgical resection is the mainstay.
Prognosis varies.
Yes, based on grade. Low-grade chondrosarcomas have a good prognosis, but high-grade ones are more aggressive. There's also a particularly nasty variant called dedifferentiated chondrosarcoma, which behaves very aggressively and has a very poor prognosis, less than 10% 5-year survival.
Okay, now for the technically most common primary bone malignancy, multiple myeloma.
Right. It's a cancer of plasma cells, a type of B cell that proliferate in the bone marrow.
How does it present in the bones?
Classically causes multiple, small, well-defined, punched-out olytic lesions throughout the skeleton, particularly the skull, spine, and pelvis. Interestingly, these lesions are often cold on a technetium bone scan in about 30% of cases because there isn't much reactive bone formation.
What do the cells look like?
Under the microscope, the malignant plasma cells often have a characteristic eccentric nucleus and abundant cytoplasm, sometimes described as having a signet ring appearance.
Treatment.
Primarily medical, involving chemotherapy, targeted therapies, and often bisphosphonates to reduce bone breakdown and fracture risk. Orthopedic surgery is often needed for stabilizing impending or actual pathological fractures, sometimes using techniques like vertebroplasty or kyphoplasty for painful spinal compression fractures.
What about tumors that spread to bone? Metastatic disease.
Metastatic bone tumors are actually far more common overall than primary bone tumors. Bone is a frequent site for cancer cells to travel to from other organs.
Which cancers most commonly spread to bone?
The classic mnemonic is BLT with kosher pickle, or BLT-KP. Breast, lung, thyroid, kidney, prostate. These account for the vast majority of bone metastases.
Where in the skeleton do they tend to show up?
Preferentially in the axial skeleton, spine, pelvis, ribs, and the proximal long bones, femur, humerus areas with rich red marrow supply.
How do they destroy bone?
The mechanism often involves the tumor cells interacting with the bone microenvironment, particularly hijacking the rank-rankle signaling pathway. This pathway normally regulates osteoclast activity, but tumor cells can overstimulate it, leading to excessive osteoclast activation and rapid bone destruction, osteolysis.
Does this mechanism affect treatment?
Yes. Treatment for metastatic disease is generally different from primary bone sarcomas. The goal is usually palliative, controlling pain, preventing or stabilizing pathological fractures, maintaining function. It often involves radiation therapy to the affected area and surgical stabilization, for example, with IM rods or plates, of impending or completed fractures. Wide excision, like for primary sarcomas, is usually not the goal unless it's a solitary metastasis in specific circumstances, like renal cell. Drugs targeting the IRM-NKL pathway, like denosumab, are also used.
Okay, one last tumor to mention, benign but can be problematic. Giant cell tumor.
Giant cell tumor of bone, or GCT. Technically benign, but it can be locally aggressive and recur.
Who gets it and where?
Most commonly occurs around the knee, distal femur, or proximal tibia in young adults, typically women between 20 and 40 years old. Radiographically, they are typically lytic lesions located in the epiphysis, often extending right up to the subchondral bone.
Why is recurrence a problem?
They have a relatively high recurrence rate, maybe 15–25% after simple curettage, scooping the tumor out.
So how's that managed?
To reduce the recurrence risk, surgeons often use adjuvant treatments after curettage. This involves treating the cavity walls to kill any remaining microscopic tumor cells using things like liquid nitrogen, cryosurgery, phenol, a chemical cauterant, or packing the cavity with bone cement, PMMA, which generates heat as it cures. Denosumab may also be used.
Anything it can be confused with.
Must differentiate it from a brown tumor, which looks similar radiographically but is caused by hyperparathyroidism. Checking serum calcium and parathyroid hormone levels is important. All right, final section. Pediatric orthopedics. Dealing with the growing skeleton brings unique challenges and principles. We have to understand skeletal growth and the physis.
The physis being the growth plate.
Exactly. That cartilaginous area near the ends of long bones responsible for longitudinal growth. It has different zones. The reserve zone, the proliferative zone, where cells multiply, and the hypertrophic zone, where cells enlarge and calcify.
Which zone is the weak link?
The hypertrophic zone is structurally the weakest part of the physis, and that's typically where fractures occur.
And injury to the physis carries specific risks.
Yes, the main risks are premature closure of the growth plate, leading to growth arrest and potentially a leg length discrepancy, LLD, or partial closure leading to an angular deformity as the rest of the physis continues to grow.
But kids' bones also heal and remodel incredibly well, right?
Amazingly well. This is a major principle in pediatric fracture care. Fractures, especially those closer to the growth plate and in younger children, have significant potential to remodel or straighten out over time as the bone continues to grow.
Can you give an example of that remodeling potential?
The proximal humerus, the top of the arm bone near the shoulder. About 80% of the humerus's longitudinal growth comes from that proximal physis. This means even significantly angulated fractures there in a young child can remodel almost completely straight over time, allowing for less invasive treatment.
How do we classify fractures involving the growth plate?
Using the Salter-Harris classification, types I through V, it's fundamental.
Can you quickly run through them?
Type I goes straight across the physis, type 2 goes across the physis and then up into the metaphysis, the most common type. Type 3 goes through the physis and then down into the epiphysis, joint surface. Type 4 goes through the metaphysis, physis, and epiphysis. Type V is a crush injury to the physis. Remember Salter.
Types 3 and 4 involve the joint surface, right? That seems important.
Critical. Because they involve the articular surface, they require perfect anatomic reduction to prevent joint incongruity and later arthritis. Types 3, 4, and especially V also carry a higher risk of growth disturbance.
What's the main treatment principle for physical injuries?
Anatomic reduction is paramount, especially for types 3 and 4. If internal fixation is needed and has to cross the physis, the rule is to use smooth K-wires whenever possible rather than threaded screws to minimize further damage to the growth plate.
And if growth disturbance does happen, LLD or angular deformity?
That requires careful monitoring. If a bony bar forms across the physis causing tethering, it might require surgical resection of the bar, but usually only if less than 50% of the physis is involved and there's significant growth remaining. Otherwise, corrective osteotomies or limb lengthening procedures might be needed later.
Let's talk specific pediatric fractures. Hip fractures in kids.
Thankfully rare, but very serious when they occur. They carry an extremely high rate of avascular necrosis, AVN, of the femoral head, especially in younger children between 3 and 8 years old with fractures close to the head, femoral neck fractures. Prompt, stable fixation is essential.
What about femoral shaft fractures in kids?
First point. In a pre-walking infant or toddler, a femur fracture should always raise suspicion for non-accidental trauma or child abuse. You must consider it.
How is management different based on age?
It varies significantly. Infants might be treated in a Pavlik harness. Toddlers often go into a Spica cast, a large body cast. Older children, maybe 5-11 years, are often treated with flexible intramedullary nails inserted down the femoral canal. Adolescents might get rigid IM rods similar to adults, or sometimes plating.
Is there a risk with putting rods in young children?
Yes, a specific risk. Inserting a standard rigid IM rod through the top of the femur, piriformis fossa entry, in a skeletally immature child can damage the blood supply to the femoral head, potentially causing AVN. That's why flexible nails inserted differently or plating are often preferred in the younger age group.
Moving to the elbow in kids, supracondylar humerus fractures are common.
Very common, usually from falling on an outstretched hand. The critical issue here is neurovascular assessment.
Which nerve and artery are most at risk?
The brachial artery can be injured or entrapped in the fracture, potentially leading to ischemia or compartment syndrome. The nerve most commonly injured is the anterior interosseous nerve, AIN, a branch of the median nerve.
How do you check the AIN?
Ask the child to make the OK sign, touching the tip of their thumb to the tip of their index finger. If they can only make a flat pinch instead of a circle, the AN might be injured. Any vascular compromise, absent pulse, poor perfusion, requires immediate reduction. Treatment is usually urgent closed reduction and percutaneous pinning, inserting K-wires through the skin.
What about ankle fractures in kids nearing skeletal maturity?
As the distal tibial growth plate starts to close, typically from medial to lateral, you can get complex fracture patterns called triplane fractures.
Why triplane?
Because the fracture line runs in 3 different planes. Sagittal, through the epiphysis like a Salter 3 on the AP view, transverse across the physis, and coronal up through the metaphysis like a Salter 2 on the lateral view. They require careful CT assessment and often surgical fixation for anatomic reduction.
Okay, shifting to developmental conditions. Developmental dysplasia of the hip, DDH.
This is a spectrum of abnormalities affecting the development of the hip joint, ranging from mild instability or shallowness of the socket, acetabulum, to frank dislocation.
Are there known risk factors?
Yes. It's more common in firstborn children, females, those with a positive family history, and babies born in the breech position.
How is it diagnosed? Newborn screening.
Yes, newborn screening is crucial. The Ortolani test, feeling a clunk as a dislocated hip reduces back into the socket, and Barlow test, feeling the hip slip out of the socket with gentle pressure, are performed. In older infants, signs might include limited hip abduction, difficulty spreading the legs for diaper changes, or the Galeazzi test, apparent leg length discrepancy when hips and knees are flexed.
What's the best imaging?
In newborns and infants under about 4 to 6 months, the bones aren't fully ossified yet, so ultrasound is the imaging modality of choice to visualize the cartilage and hip position. X-rays become more useful later.
How is treatment guided by age?
Treatment is highly age-dependent, but the goal is always to achieve and maintain a stable concentric reduction, getting the ball centered in the socket.
So for newborns?
For infants up to about 6 months old with reducible hips, the primary treatment is usually the Pavlik harness, a dynamic brace that holds the hips in flexion and adduction to encourage the socket to deepen.
What if the harness fails or the child is older?
For ages roughly 6 to 18 months, treatment often involves a closed reduction under anesthesia, confirmed with an arthrogram, dye injected into the joint, followed by immobilization in a spica cast for several months.
And for toddlers or older children?
Over about 18 months, closed reduction is less likely to succeed. Treatment usually requires open reduction surgery, often combined with bony procedures like a femoral osteotomy or pelvic osteotomy, like the Salter or Pemberton osteotomy, to correct the bone shape and improve stability.
Okay, a couple of other key developmental hip conditions. Legg-Calvé-Perthes disease.
This is osteonecrosis, a vascular necrosis, of the proximal femoral epiphysis, the growing end of the femur head. It typically affects children between 4 and 8 years old, more commonly boys. The cause isn't fully understood. Generally better if diagnosed at a younger age, under 6, and with less head involvement. Treatment aims to contain the femoral head within the acetabulum while it heals and remodels, often using bracing or sometimes osteotomy.
What about slipped capital femoral epiphysis, SCFE?
This occurs in adolescents, typically between 10 and 16 years old, often those who are overweight. It's essentially a fracture through the hypertrophic zone of the proximal femoral physis, causing the femoral head epiphysis to slip off the femoral neck, usually posteriorly and medially.
How does it present?
Often insidiously, with vague hip, groin, or even referred knee pain. A key clinical sign is obligatory external rotation of the hip when it's flexed.
Is it classified by stability?
Yes, critically. A stable slip means the adolescent can still bear weight, maybe with crutches. An unstable slip means they cannot bear weight even with crutches. Unstable slips have a much, much higher risk of developing AVN.
How is SCFE treated?
The standard treatment for almost all SCFEs, stable or unstable, is in situ percutaneous screw fixation. This means placing 1 or 2 screws across the physis to stop the slip from progressing further, without attempting to reduce the slip back to its original position.
Why not try to reduce it, especially the unstable ones?
This is a crucial point. Attempting to forcefully reduce an unstable SCFE dramatically increases the already high risk of causing AVN of the femoral head. So the principle is accept the slip, pin it in situ. Stabilizing it where it is prevents further slippage and allows the physis to close.
Got it. Okay, 2 quick final conditions. Congenital talipes equinovarus.
Commonly known as clubfoot. It's a complex congenital foot deformity involving 4 components. Equinus, plantar flexion, varus, heel turned inward, cavus, high arch, and adduction, forefoot turned inward. CVE is the mnemonic.
How's it treated now?
The Ponseti technique has revolutionized clubfoot treatment. It involves gentle, sequential manipulation and casting, gradually correcting the deformity over several weeks, often followed by a small procedure to lengthen the Achilles tendon and then bracing to maintain the correction. It's highly successful non-surgically when done correctly.
And lastly, Osgood-Schlatter disease.
Very common cause of knee pain in active adolescents, especially during growth spurts. It's a traction apophysitis, inflammation, and irritation of the tibial tubercle growth plate, where the patellar tendon inserts caused by repetitive pulling from the quadriceps muscle during activities like jumping and running.
Freeman.
Almost always conservative. Activity modification, reducing jumping, running, NSAIDs, ice, stretching. It's self-limiting and usually resolves once the tibial tubercle fuses, though a bony prominence may remain. Hashtag tag outro.
So after covering that huge landscape, what does this all really mean for someone trying to achieve that professional level of mastery in orthopedics?
Well, I think we've seen that it's about synthesizing an enormous amount of information. Mastery isn't just knowing the classifications or the surgical steps. It's about recognizing the critical nuances in each situation.
Like what specifically?
Like understanding the absolute time sensitivity of compartment syndrome or an open fracture debridement versus the need for patience and allowing swelling to resolve before fixing a pylon fracture. It's knowing why meniscal preservation is now prioritized to stave off long-term arthritis, or why you absolutely don't reduce an unstable SCFE.
So it's the judgment behind applying the knowledge.
Exactly. Knowing the why behind every protocol, every classification, every surgical choice, that's what elevates care from competent to expert. The journey we took, from high-stakes trauma impacting immediate survival, all the way to the developmental future of a child's hip. It covers that entire spectrum of judgment.
And thinking back to our discussion on joint replacement, arguably one of medicine's biggest success stories, we synthesized that key data point about technology.
Yeah, that finding that advanced tools like navigation and robotics, while technically brilliant at hitting alignment targets,
Haven't yet definitively shown better long-term implant survival or better function for the patient compared to well-executed traditional techniques.
which really does lead to a provocative thought for you, the learner, to mull over as technology continues to evolve at lightning speed.
Which is?
In a field like orthopedics, which is so fundamentally defined by the precise restoration of human anatomy and biomechanics, how far can purely mechanical precision, however advanced, actually push patient outcomes? Is there a ceiling?
A ceiling imposed by biology.
Perhaps. A ceiling imposed by the intrinsic biological factors, the patient's own healing capacity, the quality of their bone, their individual inflammatory response to wear debris, the critical handling of the soft tissues during surgery, factors that technology alone might struggle to overcome.
So the final question for the listener to ponder is,
What essential human element of orthopedic expertise, that blend of biological understanding, surgical judgment, and soft tissue finesse, will future technology find most challenging to replicate? Where does the art still hold sway over the algorithm? That balance between harnessing technology and respecting biology seems like it will remain the core of elite orthopedic practice for the foreseeable future.